Good afternoon. It's a great pleasure for me to represent data I just presented at the remote event on solutions for venous and arterial disease through the international network. Today, I would like to discuss new targets in venous thromboembolism management. I believe it's very important for those who do not remember the past are condemned to repeat it. And I am a student of history when it regards to venous thromboembolism, and I think we've learned many things over the years, and we need to keep those in mind and not discard them because they are old. For one thing, it has been traditional that acute VTE associated with a major transient risk factor has a low risk of recurrence after ceasing anticoagulation, less than 3% within 5 years. And all major guidelines agree that anticoagulation can be discontinued after a 3-month period. On the other hand, lifetime risk of recurrence in patients with an unprovoked events have a 30 to 50% incidence of recurrence within 10 years, and they do merit ongoing anticoagulation. More recently, it has become apparent that this dichotomy fails to identify some patients with provoked VTE who have a high risk of VTE recurrence and some with unprovoked VTE who have a low risk of VTE recurrence. These events in my practice over the years occurred much too often. Detailed individual risk assessment of these patients between provoked and unprovoked hasn't been done in the past. In my opinion, trying to fit everyone into a single shoe size is not the best approach, because then you lose all the details and you can't pick out those that are really the highest risk. We know that stepwise increasing venous thromboembolism results with decreasing tertiles of adjusted vitamin D. And so in my patients, I've always made sure that we measure vitamin D levels and keep them in the normal range. One of the important features of deep vein thrombosis is the presence of residual venous thrombosis changes over time. This study assessed these changes after unprovoked deep vein thrombosis of the lower limbs, the extended DOACs study. There were 409 patients, and that comprised of a third of the patients without residual vein thrombosis and 2/3 with residual vein thrombosis. In those patients that had residual vein thrombosis, they were treated for another 21 months. And recurrent VTE occurred in 13 of the 273 patients, while major bleeding was seen in 3 of these cases. So there was more clots than bleeding. 1 year after stopping the anticoagulants in the residual venous changes group, the rates of recurrent thrombotic events were 1.4% in those who didn't have residual vein changes, compared to 10.4% with residual changes. Total time, 3 years since the original diagnosis. So these results indicate that in patients without residual venous changes, a short period of treatment with vitamin K antagonist was sufficient. In those that had persistent changes in their venous system, treatment extended to 2 years substantially reduces, but didn't eliminate, the risk of recurrent thrombosis. It was reduced from 10.4% to 1.4%. The authors of this study used a simple algorithm in order to determine the presence of residual changes, and that is thrombus occupying 40% of the diameter before and after compression. Here are some results from my own practice. On the left, you see a normal venous valve from the femoral vein, and this is on duplex examination, and the very filamentous nature and beautiful characteristics of the venous valve. When thrombosis occurs, fibroblasts invade the clot and can result in serious fibrotic changes. And this next picture you see is a patient with post-thrombotic syndrome with significant residual changes. And this was 1 year after a DVT. We see in the next picture a patient after 3 months, which had significant thrombosis in the popliteal vein. And on cross-section, we see the same thing below. They're not the kind of patients that I'm inclined to stop anticoagulation. Similarly, here's a common femoral vein. It looks like there's a rock in the center of it, very low flow. And then here you see massive reflux in the popliteal vein and a grossly deformed valve. Remember that filamentous picture above, and look at the thickened valve picture below. These are all significant changes, and in these types of patients, throughout my practice at least, I continued anticoagulation. Another important feature of determining whether or not patients after an initial period of anticoagulation should be treated further not only results from taking a look at residual changes in the veins, but also D-dimer and factor VIII levels. This is a study from 2008, and this was looking at recurrent venous thrombosis in 336 patients with a first episode of idiopathic VTE. Patients who had both tests normal, D-dimer and factor VIII levels, had a recurrence rate of 6.4% during the 2-year follow-up period. Those with an abnormal D-dimer and normal factor VIII, 17.4%, and the reverse, those with a abnormal D-dimer, abnormal factor VIII and a normal D-dimer, 18.7%. So the recurrence rate in those with both tests abnormal was 34%. So when I saw this, I started doing it in my patients, particularly because I had some that had broken through with recurrent thrombosis after a simple provoked events. And what I also decided to do after taking patients off anticoagulation and then doing the test, found that 10% of them were abnormal on anticoagulation. So then there was no sense stopping anticoagulation, so that we do the tests before we stop anticoagulation to see who remains at high risk of thrombosis. In addition to that, we have the Caprini Score, which is a thorough history and physical. And I'm indebted to all the brilliant people around the world that resulted in the creation of this score that bears my name. Without them, we wouldn't have a score. We know as the number of risk factors goes up, the incidence of venous thrombosis increases. We know that there is a power of each risk factor regarding that risk factor's ability to cause a clot. Low risk causation for hormones or bed rest, high risk causation for pancreatic cancer or esophageal cancer. Combining the number of risk factors and their relative weights results in a synergistic algorithm that predicts VTE events. As VTE events increase as the score goes up, 2, 3, 4, as indicated here in general surgery. And the score has now been validated in about 5 million patients, including more than 200 publications worldwide. I also use these risk factors and scores to help make a decision about continuing anticoagulation. So let's take a look at this. These are the things that I use during my practice: vitamin D, factor VIII, D-dimer, Caprini Risk Score, and residual changes. But there are many brilliant investigators around the world that have produced additional scores. We talked about the DOACs score. There's the DASH score, the Vienna prediction score, the HER2 score, the L-TRIP score, the AIM-SHA-RP score. Many, many roads to Rome. Now, in my opinion, taking all of those data from all of those scores and putting it into a machine learning model, we can perhaps teach the computer how to evaluate for presence of recurrence. We know that you can fly airplanes using the computer. We know that you're now able to drive cars remotely using the computer. And so why can't we teach the computer to see who is going to get a recurrent clot? Now we know that if we test that model, which I've shown you above, on known thrombosis patients, that the model probably will do pretty well, but it'll make some mistakes. And then we need to add other risk factors identified in the mistakes to perfect the model. Examples: diabetes requiring insulin, HIV infections, blood transfusions, morbid obesity, recurrent cancers in certain high-risk populations, such as multiple myeloma. We've also seen this in other diseases involving the hematologic abnormalities that are not necessarily malignant, but are individual risk factors for thrombosis. Additional EMR data, including laboratory measurements, maybe even common measurements that we more or less overlook. And finally, repeat training of the model over and over in order to figure out who has this disease. One of those additional risk factors I was wanting to mention was sickle cell disease, also thalassemia, all these different things. And so eventually, what I'm hoping in the future, and it'll take time and it'll take work and there'll be many false passages, but can't we come up with one universal way to be able to predict who will get a recurrence? Now, the direct oral anticoagulants have been a great advance in far as new developments are considered. They're not necessarily that new now, but they're very important. And they've been shown to be effective as warfarin at preventing recurrent VTE with less bleeding than warfarin, but increased bleeding compared to placebo. And they're not recommended for triple positivity antiphospholipid antibody syndrome, pregnancy, and patients with artificial heart valves. Multiple guidelines now recommend the treatment of cancer-associated VTE with the direct oral anticoagulants after careful assessment of bleeding risk and drug-drug interactions. Oftentimes, having to give one a shot of low molecular weight heparin daily for 6 months has been a daunting task, very expensive, and not very acceptable by a lot of the patients. Using the direct oral anticoagulants greatly simplifies that process. One must be careful, however, when patients are on certain drugs, anti-immunotherapy drugs, for example, and also in patients who have GI malignancy or GU malignancy, where the low molecular weight heparin may still be considered as first-time treatment. Another interesting aspect of at least 2 of the DOACs that are standalone for VTE treatment. So once a clot forms, you just start the drug right away. And by doing that, you get an immediate plasma level of anticoagulation. And there are some studies and indications that in those using those drugs, at least one of those drugs in particular, may decrease the incidence of post-thrombotic syndrome due to more rapid resolution of the clot and less residual changes. Now, recently that's come under question with a brand new article on the post-thrombotic syndrome in patients with venous thrombosis treated with dabigatran or warfarin, a long-term cross-sectional follow-up of the RECOVER and RECOVER-2 databases, huge databases showing the value of dabigatran compared to vitamin K anticoagulants for the treatment of venous thromboembolism. But in this study, the patient-reported Vela Alta scores and quality of life questionnaires were sent by mail to the respondents who agreed to participate from selected countries. So this didn't represent the total population of Resolve and Resolve 2, just selected part of the population. And not only that, but 36% of the respondents were seen in clinic. The remainder were contacted for a telephone interview. No data regarding the physical exams was reported, as well as no analysis of the accuracy of the survey information compared to the in-person exams. So in those people that did come in to be seen, were their findings commensurate with what they wrote in the questionnaire? There was no duplex scan available to correlate the suggested changes. And there was no mention of compression use. Now that's a very hotly debated topic in the prevention of the post-thrombotic syndrome. And there are multiple studies that show advantages of doing that. There was one study, the SOX trial, that said it wasn't valuable, but the SOX trial, when we took a further look at it, compared 2 compression stockings, a low reverse compression and a standard higher graduated compression. So there were no control group as such because both stockings produced compression. All that can be said is compared to those 2 stockings, there was no difference in the post-thrombotic syndrome. Parsh has also emphasized to us and shown documentation that immediate application of appropriate compression to the legs is very important to reduce not only symptoms, but eventual recurrent events and also the post-thrombotic syndrome. In addition to that, 11% of the patients in the Resolve and Resolve 2 studies were started on unfractionated heparin. You know, with dabigatran, you have to use heparin or low molecular weight heparin and then bridge them to dabigatran. So in that bridging process, we don't know how well done the anticoagulation levels were using unfractionated heparin, because, you know, it only has 50% bioavailability, and you need constant PTT exams to get the blood into the proper level, or factor 10A assays. And also, warfarin patients were in range only 51% of the time. So the prevalence of PTS, recurrent VTE, and quality of life changes were comparable in the two groups. Another problem was that the Villalta scores were calculated when more than half of the 11 items were available, so-called the half-item rule. The prevalence of PTS in patients with PE without DVT, by the way, which is very interesting, was almost as high as after DVT. Comparing this study to those using residual thrombotic duplex scan changes and detailed physical exams to assess for PTS, in my opinion, is not possible. Further studies controlling the numerous variables in DVT patients will be required before evaluating the protective effects of DOACs regarding PTS incidence. Another new development is the use of micronized purified flavonoid fraction together with rivaroxaban to improve the clinical and ultrasound outcomes in femoral popliteal thrombosis. Group 1, standard rivaroxaban therapy for 6 months. Group 2, standard rivaroxaban therapy and MPFF, 1,000 milligrams a day for 6 months. Duplex ultrasound every 2 months, and a Marder VCS score and Villalta scores assessed at 6 months. At 6 months, the mean Villalta score in the MPFF group was significantly lower compared with control. PTS was diagnosed in 20% of the patients in the experimental group and 57% of the patients in the control group. So the experimental group cut by more than half the incidence of PTS over the period of observation. Statistically significant VCDS scores and Marder scores were also seen in the combined group. Full recanalization of the popliteal vein at 6 months was observed in 80% of the combined MPFF rivaroxaban group compared to 57% with rivaroxaban alone. The authors conclude that MPFF and rivaroxaban can reduce the incidence of PTS at 6 months in patients with proximal DVT and increase the speed of deep vein recanalization. Now, before the turn of the 20th century, there were 4 experiments that proved that the activation of the coagulation system had multiple consequences. And we only learned this due to the pioneering work of Oscar Ratnoff, a famous hematologist, who also, by the way, came up along with Davies with a clotting cascade. And as a matter of fact, he always was kind of perturbed that he didn't win the Nobel Prize for this. In any event, he showed that with activation of factor 12, the platelets are activated with platelet plugs. Coagulation occurs with the formation of fibrin. Fibrinolysis is stimulated with the clot dissolution and the presence of fibrin split products. But not only that, the inflammatory pathways were also activated, the so-called cytokine storm and complement activation, C1, C4, C5. But as well as the immunologic pathways without an antigen-antibody response, which was usually thought to be necessary to cause the kallikrein system and kinin systems to become activated. Now, what did that produce clinically? Thrombosis, fibrinolysis, increased vascular permeability, vasodilatation, bradycardia, angioedema, histamine release, and hypotension. What a complex bodily mechanisms. And here's an important historical observation, and I need to repeat it here. Oscar said, "The thesis of my talk is not new. We think about clotting, fibrinolysis, immune reactions, and inflammation as if they were separate and separable processes. In truth, these distinctions are man-made. In real life, it is the body as a whole that responds to the injury. The processes through which it defends itself are interlocked like pieces of a jigsaw puzzle. We may be intrigued by the intricate pieces of the puzzle, but the picture emerges only when they are put together. And we need to have clotters talk more to the inflammatory doctors and the immunologists in order to get a better understanding of, for example, COVID-19. And COVID-19 is this whole tangled hemostatic web on steroids, so to speak. And just think, do you think that anticoagulation alone can solve all of these problems? Of course not. But let's talk about factor 12. Factor 12 is the initiating pathway in the extrinsic system of clotting. And factor 12 inhibition was studied in baboons. And factor 12 inhibition prevented the activation of kallikrein, kininogens, and the clotting systems induced by heat-activated staph aureus. Blocking factor 12 decreased complement activation and inflammatory cytokines, preserved organ function, and saved Staphylococcus aureus challenged baboons. They used the anticoagulant factor 12 neutralizing antibody 5C12 in this baboon model. Such indications include prevention of sepsis or its mitigation in severe infections in which factor 12 activity is involved in its pathogenesis. So blocking 12 activity would be a very important thing to counteract these very severe inflammatory induced infections. Now we know that factor 12 does not affect hemostasis, and those deficient do not have an increased risk of bleeding. Oscar Ratnoff discovered this factor 12 in John Hagemann and named the factor after him. But he later followed John Hagemann and was tragically found out that John, who had this defect in factor 12 deficiency, died from a fatal pulmonary embolism after an accident. And so we know that factor 12 inhibition, though, may be particularly effective in settings where blood is in contact with artificial surfaces, where the contact activating pathway of thrombin generation gets triggered through 12, 11, 8, 9, 5, 10, and calcium, and so forth. Where would some of these things be? Cardiopulmonary bypass, extracorporeal membrane oxygenation, chronic indwelling vascular catheters, ventricular assist devices, or artificial heart valves. Very, very interesting possible uses. Plasma factor 12 levels do not correlate with the risk for VTE, stroke, and possibly MI. Of course not, because that's not the only way that clotting gets activated. There's the intrinsic clotting pathways that occur as well. What about factor 11, which comes right after factor 12 as the second contact activating pathway as a target for new anticoagulants? We know that factor 11 deficiency, Rosenthal's disease in hemophilia C, is associated with attenuated thrombosis in factor deficient mice and associated with only a mild bleeding diathesis. Kids with Rosenthal's disease also really don't bleed very much unless they're challenged surgically or with trauma. Factor 11 knockdown does reduce venous thromboembolism compared with low molecular weight heparin in an early study of total joint replacement after knee arthroscopy. And it doesn't increase the bleeding. And it's given as an infusion of over 30 minutes, and it lasts a month. So it's postulated that the prevention of unprovoked VTE is a potential indication because of the high risk of recurrent thrombosis in these patients, which is 30%, and the ease and efficiency of giving this, and the low risk of bleeding particularly. E-selectin. E-selectin is another major new development, E-selectin inhibition, of course. And what is E-selectin? It's a glycoprotein expressed from activated endothelium, facilitates thrombosis, directly modulating neutrophil and monocyte activity. We, which that means Tom Wakefield, who lent me this slide, identified E-selectin as an important regulator of thrombus formation and fibrin content in a mouse venous thrombosis model. Endotoxin-induced tissue factor-mediated anticoagulation is enhanced in humans carrying the E-selectin allele. Not only that, but if they're homozygous, they have an increased risk for VTE, which highlights the importance of E-selectin in the creation and amplification of venous thrombosis. E-selectin has been shown to be efficient at raising the affinity and avidity of CD18, which are the MAC1 integrins, which support neutrophil trafficking to the sites of acute inflammation and recruit further platelets and blood cells. Selectin inhibition in the setting of induced DVT results in a marked decrease in thrombosis and vessel wall injury. And as you may or may not know, the Wakefield group has had one of the longest and most successful experimental programs involving experimental venous thrombosis. And they're using the baboon model, and they do it in the iliac vein. And this is a series of experiments that were done that I just described. And this is the lumen patency after 21 days in the control animals. And you can see a highly statistically significant increase in patency at 21 days using an E-selectin inhibitor. An E-selectin inhibitor and low molecular weight heparin didn't change very much, a slight improvement in the lumen patency, and low molecular weight heparin alone had a similar lumen patency as the controls. Now let's talk about vessel wall inflammation, which is an incredibly important factor with that fibroblastic proliferation that leads to the chronic changes and eventually PTS. The control animals, you can see their level of expression. In the patients treated with E-selectin for 21 days, a dramatic lowering of vessel wall inflammation. But here's the most exciting news. Combining that with low molecular weight heparin further lowered the vessel wall inflammation. Now just think about it. Suppose we used a product like Sulodexide with all of the anti-inflammatory changes, or even one of the DOACs, or MPFF, or a combination of all of those. Think of what might happen in terms of amplification of this phenomenon. You can see the control, the low molecular weight heparin alone did not reduce the inflammation as much as I have just described. And here I'd like to share a cartoon that Tom Wakefield has supplied to me, showing how selectins are involved in thrombosis and inflammation. With endothelial platelet cell activation, selectins become upregulated on their surface, as you can see on the endothelium. These receptors are on leukocytes. This leads to leukocyte-leukocyte and leukocyte endothelial platelet and leukocyte-leukocyte interactions with the release of procoagulant microparticles and thrombosis amplification, as seen here. At the same time, other inflammatory cells come in. They bind by receptors such as the MAC1 receptor. This leads to further fibrin formation, platelet accumulation, and the release of nuclear material, also known as nets. Finally, other additional red cells come in, and this leads to a very cellular thrombosis. Sulodexide is a mix of low molecular weight heparin and dermatan sulfate. Look at all of the actions: anti-thrombotic, profibrinolytic, endothelial protective. Think about that in that baboon model we were talking about, combined with the E-selectin inhibitor. Restoration of endothelial glycocalyx, capillary permeability control, anti-inflammatory, growth factor release control, proteolytic enzyme activity control, capillary permeability control, and oxidative stress control, and also they're lipolytic. And here is the Sulodexide study in unprovoked venous thromboembolism after the patients were initially treated. This was a secondary prevention. And these patients were randomized to get Sulodexide twice a day or placebo for 2 years, plus elastic stockings. The recurrence rate in the Sulodexide group was cut in half compared to the control patients. No major bleeding occurred, and Sulodexide given after discontinuation of anticoagulation treatment reduced the risk of recurrent VTE in patients without an increased bleeding risk. Now, this prompted an additional large study because elderly patients are more prone to bleeding complications. So this was called the JASON study, which is the design and rationale of a randomized placebo-controlled trial on the efficacy and safety of Sulodexide for extended treatment, secondary treatment in elderly patients after a first venous thromboembolism. And these patients are randomized to one of 2 doses compared to placebo, of course, after the initial treatment with anticoagulation. And we're hoping to have the outcomes, which is a composite of death for VTE and recurrent VTE and occurrence of major bleeding sometime in the next year. Also notice that Sulodexide was used in patients with chronic venous symptoms, and 3 months of therapy lowered the incidence of heaviness, pain, cramps, and paresthesia. Not only that, but in another study, it was shown that the post-thrombotic syndrome was prevented better by Sulodexide, seen in the yellow, compared to standard treatment in the red, or placebo, or ASA in the gray. Also, very recently, there was some discussion about the use of Sulodexide in COVID-19, and it definitely was shown to have a reduction in the need for supplemental oxygen or hospital care. Lower serum levels of D-dimer and CRP were seen. There was no effect on total days or mortality in the hospital, but these are very preliminary results due to the pandemic lockdown. And now another new development, which is very, very critical, are the new development in compression therapy. There's a variety of mobile compression devices. I only have time to show one here. And these devices all have good hemodynamics comparable to the traditional units. They have long battery lives. There's no wires, there's no tubes, there's little or no noise. Bluetooth technology can be built in, so you can also track the amount of minutes a day they're used, and also ambulation. And this can be used in a formula to better understand the relationship between ambulation and compression therapy uses in the incidence of, in the prevention of initial and recurrent DVT. They're adjunctive therapy for DVT, especially in patients that can't wear stockings or won't use other devices. It allows full patient mobility. And what's interesting is that patients that stand all the time, checking groceries in an assembly line, at a reception counter, they stand long periods, ideal for those types of patients. And those patients that are driving trucks or vans or buses, long distances, that's also an advantage. And of course, not to mention, you can fly halfway around the world in a day, but that requires some very long flight times. And this is particularly suited to airline travel. Now, I wanted to touch another subject before we stop. And there's a great deal of debate regarding dosing in COVID-19 trials. There's a huge trial out that showed that prophylactic doses of anticoagulation were just as good as therapeutic anticoagulation in VTE events and death in patients in ICU. However, in patients not in ICU, therapeutic doses were better. Then another huge study comes out showing no. Use prophylactic doses, not therapeutic doses. What is going on? Well, the problem as I see it is that all of these trials are trying to put everybody in the same shoe. You can't do that. History has taught us you can't do that. Why have we not applied lessons learned regarding thrombosis risk assessment prior to the pandemic? Can the level of risk assessment be used to predict VTE and death? I'd just like to show you what I could call the Boeing Airbus story. We have two major aircraft manufacturers. We also have two very major risk assessments. And there's many roads to Rome, but for goodness sake, you've got to do an assessment. So recently a study was done comparing in COVID-19 patients, both the IMPROVE and the Caprini scores. And a linear increase in scores according to risk level were associated with both decreasing the rates of VTE and mortality, and were independent predictors of these events. Both scores worked for this. So why wouldn't you use a score? These results indicate the value of risk assessment in COVID-19 using either model. And of course, we need further studies. We always need further studies. And I'd just like to highlight what we saw with the Caprini score, because it goes up as to levels. We don't just have low and high. And as those levels increase, the risk of venous thrombosis goes up. What a difference from the patient who has 3 to 4 score, where it's less than 5%, to 28% for patients with a score of 9 and above. And we don't even know how much more above that. What about mortality? Again, those patients that are low or moderate risk, small incidence of mortality. but it's 80% if the score is over 9. So how can you treat all patients in ICU with the same dose when you know they have different risk factors? So in conclusion, I would like to emphasize something that Sergio Gianzini has put on the map. And this phrase was brought to me by my dear friend in Maine when he said, Joe, he said, your risk assessment is simple. Every time you see a patient, you can't just treat them as a stranger. You've got to interrogate them. So you find out as much about them as you would about a good friend. And then you can protect them. So you would never treat a stranger. And of course, you would never kill a good friend because you would give them appropriate protection. So I'd like to thank all of you for watching this. I would also like to encourage you all to stay safe and please follow history and follow risk assessment and what we have learned. Thank you very much, and you all have a wonderful day.